Thanks for coming. I'm flattered there's a load of people here still on the last afternoon, so that's really kind. I thought, given that you've seen so many presentations, and you might not remember all of them, the key points, this is the one with the bloke with the massive condom. So this is from a piece of work we did when I used to work at Dr. Foster, where we were trying to encourage people in Brent to not have sex until they were adults. So we did some Burberry condoms. We did some condoms with pictures of genital warts on the cover. We went to football matches and gave out magazines that were kind of targeted at that group, explaining that chips is not a vegetable, and so on. So we kind of took some quite disruptive approaches to social marketing, if you like. And interestingly, as I kind of get into this bit, and this feels like the kind of the Inequalities stage at Glastonbury, you know, it's the kind of the best one, sort of that people go, I wish I'd gone over there to see Loyal Carno. It's much better than Elton John over here. So there's been some fantastic presentations over the 2 days, and well done. So my heart rate's gone up by about 40 points since you said you're really nervous. So that's your fault. It's fine. I'll settle in. Spoiler alert, when we get to the data about ethnicity, the one thing that you might take away from what I will say is we've seen lots of presentations over the last couple of days with graphs show, and mea culpa, there's something here, IMD and census characteristics from the census that say poor people aren't as healthy as posh people. We all get that, but there's a lot of slides which have kind of said that. So I think it's really important to sort of hold ourselves to what Peter said this morning, which is be really clear what it is you're actually asking and be really clear what you're actually going to do with it. It's not good enough to just stand up and put an IMD chart up that says that poor people die a bit younger or are more likely to have stroke or whatever it is. Be very clear, and I think you should challenge us next year and the year after to demonstrate that we've done something based on it and it's had an effect. And it may be that it didn't work, but at least we sort of had a go. So I think that's a really important kind of point to make. We put together some slides about our department because we thought it would be useful for events like this. In broad strokes, those are the things that I'm kind of interested in. I'm lucky enough to be kind of working more nationally with people like Ronnie, with APA, and all sorts of things. But locally, those are the sorts of things I'm interested in. And I think it's really interesting, and you know, hearing examples, good examples from Manchester and from Nottingham and other places, there's a really good dialogue with the academic sector. And when the Academic Health Science Network started up, they said, what we're going to do is we're going to get the NHS, industry and academia to work together better. And I thought that sounds really good. That's nice and sort of simple and clear. And HSNs, being HSNs, decided to then go and concentrate on something else. So they kind of lost that. But I think it's really important that if you work in a hospital and you're just moaning because you haven't got any data scientists, just cross the road to the university where they've got supercomputers and loads of people who want to do masters and PhDs and so on. But don't keep moaning that you can't recruit because everyone's going to work for a bank or for Google. There's a university over there with loads of bright young people who can do this stuff for you. So that's the sort of second way. So almost 20 years ago, I presented some of this data, and we proved, working in Imperial College, that if you were from a posh background, I'll use deliberately clumsy language to make a point. If you're from a posh background, you're more likely to have your breast repaired than removed. Statistically significantly, in an NHS free at the point of care, adjusted for late presentation. Okay? Exactly the same thing happens for bowel cancer. You're more likely to end up with a colostomy bag if you're from a poorer background than a wealthier background. Again, adjusted for late presentation, and so on and so on and so on. So that's still true to some extent. Nice pithy picture of the Blairs there. Sheree got pregnant. That's a bit of a surprise. This works less well, so I've put this up to see if much has changed. Those two things on the left haven't changed too much. The only one that's changed a bit is the left one, because there's so many new railway lines and tube lines across London that places that 20 years ago would have seemed less fashionable are really fashionable now. So, Chris is it somewhere? Chris is there from Catford. The big cat, anyone knows it? Really trendy now. You have to be a very senior leader within the NHS to be able to afford to live in a cat food. You didn't need to used to be 20 years ago. Okay. Out of COVID, lots of kind of anecdote about certain groups not getting the vaccination quick enough, certain people not wanting to, nervousness. We've seen a lot of that over the last couple of days, working with community leaders to do creative social marketing. So a lot of background coming out of COVID, which said you must concentrate on inequalities a lot. We thought that it would be really important to quickly go down into our data to assure ourselves that we were delivering care sort of equitably and fairly. So to Peter's question this morning of, are we checking what the research question is? And we'll get to, did you actually do anything about it? The first one is a really simple one. Do we deliver care equitably and fairly? Okay. So people occasionally, as they do at these conferences, draw charts of IMD and so on. Do we do it in a formal way that leads us through to ops so that we can actually change things? Maybe not. I think if we all have ourselves to account, are we actually operationalising? Maybe not, actually. There's some public health people over there doing some sort of interesting stuff on some data that's a bit out of date. Are we using it day to day to change our waiting lists and push what I'll call green patients back, patients that we're seeing next week that we don't really need to see next week because they're kind of fine, and bringing red patients forward because they keep getting admitted into ED and they've had some tests in GP land which suggest that the condition they're waiting for is causing them to come into our ED more. Those are red patients. They're at the back, they need to come down to the front. Are we all actively doing that? No, we're probably not. One or two people are dabbling with it. We need to start doing that quickly and scientifically. So we had, so I just tried to conceptualize that, and bloody hell, it's like my third slide. I'll send the slides around. I got asked to do some analysis of falls by gender and by someone quite senior in our organisation, in case it's been filmed. And I said, this is definitely meaningless. No, still need it. It's definitely meaningless because that ward admits more men, men fall more often, men are frailer on that ward, and so on. You've got to kind of get over there and adjust this stuff out. So get to adjusted measures of inequality. And I've used HSMR as a kind of clunky example of going from crude mortality through to something that's not perfect, but it's probably better. Okay. Mea culpa, IMD deciles, the poorer you are, the less likely you are to come into your outpatient appointment. To Peter's question this morning, with the help of people like Tim and others, we are going to operationalise that. So we are going to live build a score on our waiting list of people about to come in, predict if they're going to DNA, predict if they're going to cancel, and then give them different strategies to adopt. Letter plus text plus phone call, letter plus text plus 2 phone calls plus taxi, if necessary, because we're mixing cancer drugs. It would be simpler for our chief executive to drive around there, get them to come in. So different strategies. People talk about it and they go, oh, it's quite difficult with the travellers, but they don't do it in a kind of like a commercial company would with strategies. It needs to work like comparethemarket.com. Okay, so that's what we're going to try and do. We have also, again, I will send these and I'll put my email up at the end. We've done some early machine learning to try and work through that. So this sort of stuff you would know, that it's difficult presenting to you lot because you know all this stuff. I mean, usually I'm presenting it to people who don't understand what these things are. So I've put some explanations in there. And I've given you a description of where you might try and get to with evaluating the regression that's come out of the machine learning. Surprise, surprise, people who previously haven't come in are less likely to come in the future. But we don't act on that. We don't tweak it by ethnicity and whether they've got English as first language and all sorts of things. So I wanted to talk about this very briefly, just to be a little bit disruptive again. The way that we talk about ethnicity is quite crude, I think. We don't talk about I've heard the intersectionality word once over the last 2 days. You know, if you're from a very, very middle class Ugandan background, that's very different to a white working class background. So talk about ethnicity and deprivations, though they're two things that sort of show the same thing, is nonsense. So we did some work during COVID. It was great fun because we had a coping notice, which meant we could kind of just do things quickly. So we profiled all of our staff and all of our patients in 1 day. And we're allowed to do that. And we showed that if you are from a Sikh background, you're off the scale for diabetes, like off the scale. Okay, we were doing it to work out if we should draw some black staff out of ITU. But we managed to analyse everyone really quickly because we had a little window of permission, and we found some really interesting things about how people present themselves to the world. So these are people who haven't given their ethnicity, but we've estimated their ethnicity from their first name and their second name. The last presentation about pulse oximetry and the temperature thermometer is really interesting because I stood outside of Vaccine Centre for 3 months, just kind of doing that. And as people walked in, the person on the desk who was going to put them in said, "Are you white British?" And I'd gone there sort of having taken my name badge off because I didn't want to, make out I was watching them as a vaguely senior person. But I had to step in and go, if this isn't a test, they all get one, all right? If you ask someone, are they white British? That sounds like a test. So stop saying that. Because some people identify as white British and some people don't. The difference between Turks and Cypriots and Brits is quite subtle, actually. Some people really want to present themselves as British and white, and some people definitely don't. So in your work in Manchester, you would know that you have to talk to people very subtly, very differently, depending on whether they're these, not just kind of go, oh, they're sort of Eastern European, which is that kind of, that census grouping together people from lots of different places. So if you take one thing away, think about how you might profile people in a much more subtle way and how you might talk to them in a different way. Okay. One last thing to mention, which is kind of about the Goldacre Review, and thanks to our college and Health Foundation for sponsoring some of this, share everything that you do really proactively. We have to come back year after year, proactively sharing the stuff that we're doing. So we've set up a little thing called Open Data Saves Lives, and we kind of created a bit of fire cover by putting everything aggressively in the open. So we did some work with the head of the murder squad, where he's got a file, and it's his idea. He's got a file of men who hit women. I've got a file in my idea of women who've been hit by men. I do a classic Venn diagram. I can find women who haven't been hit on the average, which is usually 6 times before you come to ED. I can identify families at risk earlier, potentially. And that sounds quite difficult already, doesn't it, in terms of IG? You all go, that sounds like a nightmare. But you have to be bold, and if you're acting on the side of the angels, it's okay. You have to make strong ethical arguments to be allowed to do some of this stuff, not just go, it's a bit difficult. And I'm done. That was sort of the last slide, but I was just wanting to name check AFA, but I've done that. Name check that. There you go. So.